multiple layers. In blue, I'm drawing for you the fibrous pericardium, okay? So this is really thick layer. And then there is like a thinner layer which we call serous pericardium. I'm going to draw it in red. So the first layer, it's adherent to the fibrous pericardium, okay?
Yeah.
But to the inside of it, basically. We call that a parietal serous pericardium. The next layer is adherent to the heart, okay? It's all over the heart. And we call that the visceral serous pericardium. Good?
Yeah.
So, now really important thing. The pericardial cavity is located between these two red structure. It's between the visceral and the parietal serous layers, okay? Serous pericardium. And they do ask this a lot. If they ask you what, like a patient had a tamponade, okay? Like a bleeding inside of his pericardium. And they ask you the blood is between which two layers, you must say it's between the parietal and the visceral serous pericardium, okay? So it consists of three layers from out to inner. It's the fibrous pericardium, as we saw, the blue one. Parietal layer of serous pericardium, which was adherent to the fibrous pericardium. And finally, the visceral layer of serous pericardium, which was adherent to the heart. So they write pericardium is innervated by the pharynic nerve. This is really important. Do not make the mistake of saying that it's the vagus nerve. So you know that the vagus nerve basically is this can give the recurrent laryngeal nerve. So a lot of students mistaking the pharynic nerve for the vagus nerve. They are not the same. So if I speak with you about this one, the pharynic nerve. The pharynic nerve, first of all, the vagus nerve originated from the brain, exactly from like the medulla oblongata. But the pharynic nerve, pharynic, what does the word pharynic mean? Pharynic means diaphragm, okay? Make a note about this. Pharynic means diaphragm. So the pharynic nerve supplies your diaphragm. And it originated from C3, C4, C5, keep the diaphragm alive, okay? So they supply the diaphragm. But notice, while they are descending, they are going inside of the mediastinum, which is like a structure in between your lungs. And they supply the what? The heart, okay?
Yeah.
Okay, good. Do you feel comfortable that the pharynic nerve supplies the pericardium of the heart?
Yeah.
Okay, good. So keep in mind, the pericardium is supplied by the pharynic nerve. The SA node and the AV node of the heart are supplied by the vagus nerve, okay? Good. So pericarditis may cause referral pain to the neck, arms, or both shoulder. So you're like, wait. How can how can pericarditis lead to neck pain? Take a look here. So the pharynic nerve, this guy, okay, it's going to your pericardium. So when you irritate that, the pain is going to go back to where? What is this? Your shoulder, yeah?
Yeah.
So that's why the pain refers to the shoulder.
Yeah.
Okay. So pericarditis can cause referred pain to the neck, arms, and or one or both shoulder, often the left one. Why? Because your heart is deviated towards the left, so you have more pericardium to that region. Yeah. Can you tell me, please, if the heart was located to the right, what do we call that disease?
Oh, Cartagena syndrome.
No, don't be racist. What nega? No, Cartagena. Okay.
Cartagena.
Cartagena syndrome. Come on. So. Good. So it's Cartagena syndrome, also called the primary ciliary dyskinesia. Can you tell me, please, why these patients are infertile?
So they defect the dynein in the cilia, in the sperm.
Excellent. Okay, good. So coronary blood supply. Now we are going to speak about the blood supply of the heart. This is an important topic. Okay. So. if I take a look at, first of all, the normal anatomy of the heart, the anterior most chamber of the heart is made mostly by the, which chamber?
Right ventricle.
Yes, and you remember that the apex and the lateral most portion is made by the
Left ventricle.
Good. So then you have your right atrium here and left atrium here. So if I show you a chest x-ray really quick. Yes. So if they show you a chest x-ray, please be careful. If they are showing you this region, this is the right ventricle, you know this. But if they show you this region, this is the right atrium, okay? So this is here the right atrium, okay? So, again, if they show you something like this, take a look. This is right atrium. This is right ventricle. This is left ventricle, okay?
Mm-hmm.
So again, you can see here, appreciating this picture. Okay, good. So the next thing we have the following. LAD and its branches supplies anterior 2/3 of interventricular septum. So what is this LAD? It's the left anterior descending artery, also called the maker of the widow, okay? Why? Because it's the most commonly infarcted vessel, so it's the most common killer. So if we speak about what it supplies, let's take a look. If we imagine that this is a heart, and I'm looking at the heart from up down now, okay? So there is like separation between the two chambers, and let's say that this is the left ventricle and this is the right ventricle. So the first vessel I'm going to speak about is what? The lap. So it supplies the anterior 2/3 of interventricular septum, okay? Also, it supplies the anterior surface of the left ventricle. So let's take a look. So it supplies this region, yeah, and it also supplies this region, correct?
Yeah.
Okay, good. So we call this the red one, it's what? Which vessel? Tell me, which vessel is supplying the red region?
LAD, the left anterior
Yeah,
descending.
excellent, good. Keep in mind that where does your coronary artery exit your heart? How coronary artery go from the heart to the heart? How do they get the blood from the heart?
They arise from the I forgot how to say.
No, say it. You are correct, but come on.
Yeah, coronary sinus, I guess. No.
No. If you remember, there is like this aortic valve. Okay, if we say that this is the left ventricle, sorry, left atrium, left ventricle, and this is your what? This is your aortic valve, yeah?
Yeah.
So the coronary arteries are exactly in green. I will make them exactly exit here, okay?
Yeah.
So you have a left one and you have a right one. So
How do we call this structure? I forgot like the name.
what do you mean? Aorta?
No, like the two-hole like
Osteo?
the structure where the coronary artery arises from.
I'm not sure what is the question. Oh, I think I know what you are speaking about. Are you asking about like ascending aorta?
No, the level of the aortic valve, like where is the coronary arise from?
Well, it goes exactly behind the cusps of the aortic valve. Okay, so
Okay.
if we speak about the aortic valve cusps, so coronary artery opening. If you take a look at the basically the aortic valve, it has a cusps, and these cusps, under them there is the coronary artery. This will be super important in the future. So just for the sake of completeness and for you not to forget this, take a look here. You can see here like the ascending aorta, and you can see the coronary artery exiting from it. And you can also appreciate the fact that they are drawing for you the openings of the coronary artery located in the cusps. Yeah, you can see it.
Yeah.
Okay, good. The next thing I want to show you a picture of the base of the heart, because they tend to show it. Remember, the base of the heart is like looking at the heart from upward downward, yeah? And if you take a look at the heart like this, you must know what is the most anterior chamber of the heart. What is it?
The right ventricle.
Okay, excellent. So what is this vessel? The anterior most vessel.
It's not the LAD, right? No.
Think about it. If the right ventricle is the anterior most.
No, so the right coronary artery.
No. This is a valve, a big valve. So from the right ventricle, there will come a vessel, big one. It's the pulmonary trunk. Yeah.
Yeah. Okay.
So this is the pulmonary trunk. And behind it you will have your aorta, and these two big are tricuspid and bicuspid, yeah?
Yeah.
Okay, good. So let's go back here. So the next thing you must know is like the BDA. So this is what? Posterior descending artery. So you're like, posterior descending artery, what does that mean? Well, before reaching that, I wanna just, for the sake of completeness, give you an idea about what happens after the left coronary artery exits your aorta. So this is the left one, okay?
Yeah.
What it does, like I will keep it in green, so it exits from here, and it gives the following. So this one region will go like to the back of the heart like this, okay?
Yeah.
And okay, we call that the left circumflux, okay?
Yeah.
Also, it will give one more region that will go directly down. We call that the LAD. Good?
Yeah.
Excellent. So here, as you can see, we have the left coronary artery. It's giving the left circumflux, and it's giving the LAD.
Yeah.
So they're right. There is something called the BDA, which is the posterior descending coronary artery, and it comes from where? Well, it depends on the dominance. What do I mean by that? Can you see this structure? This is a posterior look at the heart, basically. So you can see the BDA here. Normally, most of the time, it comes from the right coronary artery, but it depends on the dominance, which means like different human beings have it differently. So if we say like the patient is right dominant, it means that his BDA is coming out from his right coronary artery. Please appreciate the fact that the right coronary artery is going like this and coming from the back then, okay? So that's basically what a BDA. So if you take a look here, we have the following. A BDA supplies the AV node, and it's depending on the dominance. Well, what does that mean? Well, the dominance mean, is it coming from the right coronary artery or the left coronary artery? If you are right dominant, it means it comes from your right coronary artery. If you are left dominant, it comes from your left circumflux. Can you tell me please regarding this left circumflux, where it came from?
The left anterior descending LAD.
From the left coronary artery, yes?
Yeah.
Okay, good. The common one. So when we say an BDA is codominant, a codominant, it will be from both. So what I'm speaking exactly. So if you take a look here, you have the BDA coming from the right coronary artery. If it comes from the left coronary artery, it will be like this and going down, yeah? But if it's codominant, it will be like from both sides. So this join this, and then together they make a descending artery, okay? BDA. So tell me please, which one is the best for the patient? Is it right dominant, left dominant, or codominant?
Codominant.
Yes. Why? Because if one vessel is infarcted, the other one will supply him. Yeah?
Yeah.
Okay. So they write, a BDA supplies many structure, including your AV node. Also, the posterior 1/3 of the intraventricular septum and the posterior 2/3 of the ventricles. So let me just explain what I just said. Remember this picture I drew for you? Now I'm going to add some stuff on it. Now in green, I'm going to draw for you the regions that are supplied by the PDA. So the first region is this guy, okay? This is the posterior portion of the intraventricular septum. Also, they supply the what? The back wall, yeah?
Yeah.
And they supply the posterior 2/3 of both ventriculi, okay? Something like this. Good? You're like, okay, but there is one area left in the right ventricle. We'll speak about it later. But for now, just keep in mind that this green thing, it's coming from what? This is coming from the BDA. Yeah?
Yeah.
Okay, so they tell you also that they supply some muscles. I will go back to this in a moment. While your RCA, it supplies the SA node. But you must know that it's not dependent on the dominance. It doesn't matter. You are right dominant, left dominant, codominant, it doesn't matter. Your RCA will always supply the SA node. While if you were right dominant, your AVA will be supplied also by the right coronary artery. While if you were left dominant, it will be supplied by the left coronary artery, yeah? Sorry,
Yeah.
right will be right dominance. Left supplement with the left dominance. So, like left circumflux, you know? So, okay. So the blood supply is independent of the dominance. Infarction may cause nodal dysfunction. So if you infarct the SA node because of RCA infarction, the SA node will die, correct?
Yeah.
So you remember that if I draw a heart here, the SA node, where is its location, please? What is the location of the SA node in the heart?
Yeah, in the right atrium.
It's in the right atrium. Can you tell me, please, exactly where in the right atrium?
I think near the superior vena cava.
Excellent. Yes, you are correct. It's near the superior vena cava, near the opening of the superior vena cava. What about the AV node?
AV node, like left atrium. Oh no. It's the right atrium.
It's the interatrial septum. Yeah? It's the posterior inferior wall of the intraatrial septum. Okay. And then you have the bundle of hairs. After the bundle of hairs, you have like right and left branches. Yeah? So you can imagine that a patient who has like infarcted the SA node, it will be dysfunctional. So the pacemaker cells in the AV node will be the functional ones now, yeah?
Yeah.
What is the problem of the AV node? It's much more slower. What is the rate of the SA node compared to the AV node? Do you know?
No, I think 400 or something.
Okay, what is the normal pulse in a human being?
60 to 100.
Yes, that's correct. So that's the SA node. So that's 60 to a 100. And then you have a backup. If this first generator get destroyed, which is the SA node, the backup is the AV node, okay? So the backup, the AV node, basically it will be like 20 less. So it will be 40 until 60, okay?
Okay.
So as you can see, the patient will be, in case of AV block, the patient will be complaining of in case of SA block, the patient will be complaining of bradycardia, correct?
Yeah.
Good. Are you comfortable with this?
Yes.
Okay, good. Now we are going to speak about the we said about the left anterior descending, and we spoke about its supplement. We speak about the posterior descending artery and its supplement. Now we are speaking about the RCA, which is the right coronary artery, and its supplement to the SA node. So infarction may cause nodal dysfunction leading to bradycardia or heart block. Please tell me why bradycardia occurs? Because which node has been destroyed?
The SA node.
Yep. And who is faster, the SA node or the AV node?
The SA is faster, AV is slower.
Okay, good. Can you tell me the rate?
SA node rate is 60-100 and AV is 40-60.
Excellent. Good. So also we have some little artery called the right marginal artery. You're like, wait, we did not speak about this one. Well, yeah, look, you have your RCA. See your RCA, it's going to the back and giving the posterior descending artery. But it gives this little branch, yeah?
Yeah.
This little branch, we call it the marginal one. Notice, the only thing I did not speak about yet was that region. So let me make it with which color would you choose? Come on, choose a color.
Pink.
Pink, okay. So the marginal artery feels feminine. So here you go. The marginal artery supplies this wall, okay? So here you have the marginal one. Okay, so we had the BDA here, we had the LAD here, and now we have the marginal, okay? So, good. Now let's try to reread it really quick, but to try to understand everything that was written. So the LAD and its branches supplies the anterior 2/3 of interventricular septum. Does it make sense?
Yes.
Okay. Also, they supply something called the anterolateral papillary muscle. This I did not explain, and I will do it now. So if we say that this is your heart, it has a valve here, yes, the mitral valve. So this mitral valve is big. Thank you. So the mitral valve is connected to something called the tendini, chorda tendini, okay? And these chorda tendini are connected to other structure called papillary muscles, okay?
Yeah.
These are important. These anchor the chorda tendini to the walls of the left ventricle, which allows the leaflets of the mitral valve to close normally, correct? When they tense, basically. So if you take a look here, they mentioned that the LAD actually supplies your anterior lateral papillary muscle, yeah? So if we say that this anterior lateral and this is posterior medial, so this guy is supplied by whom? It's supplied by your LAD, okay?
Yeah.
This is super important because if the LAD was infarcted, what will happen to this guy? He will be infarcted as well, yeah? He will die. And when he dies, what happens to the leaflet it connects? It will go backward, yes?
Yeah.
When it goes backward, you will have a Rieger-Schmerber, okay?
Yeah.
Got it?
Yes.
Okay, good. So that the LAD supplies the anterior lateral papillary muscles, and also they supply the anterior surface of the left ventricle. And it's the most commonly occluded, that's why we call it the maker of the widows. So while the BDA, on the other hand, it supplies the AV node. Okay, so it supplies the AV node. And when we speak about it, there is actually an important thing you must appreciate. The BDA, well, just a second, let me show you. You remember it supplied this region, yeah?
Yeah.
Do you remember what was the location of the AV node inside of your heart?
In the septum.
Yes. Yes, but you must know where exactly in the septum. So let me show you. I cannot find a good picture, so I must show it to you on my diagram. It's if I draw a septum like this, oh sorry, if I draw a septum like this, and then this is the anterior wall of the septum, this is the posterior wall of the septum, and this is the foramen ovale. Fossa ovalis now, yes?
Yeah.
You must know that your AV node is located here, okay? It's the posterior inferior region, okay? So, why this is important? Because if you have infarction of BDA, that was the one that supplied that region, correct? So,
Yeah.
what you will have a block of what? Of the AV node. Got it?
Yeah.
Okay, good. So they write BDA supplies the AV node depending on the dominance, and the posterior 1/3 of the ventricle, interventricular septum, and posterior 2/3 of the ventricles, as we spoke about. Like it supplied this 2/3, it supplies these 2/3, so that's clear. Okay, and also it supplies something called the posterior medial papillary muscle. You're like, what is that? Well, do you remember the anterior lateral one that we said is supplied by the LAD?
Yeah.
There is another muscle called the posterior medial. So the posterior medial is supplied by the whom? The posterior medial is supplied by the other one, which is BDA.
Posterior. Yeah.
Yeah. So if this one gets infarcted, let's say that it gets infarcted. If it gets infarcted, what will happen to the chorda tendini?
Rupture, right?
Yeah, they become more loose, you know? And when they become more loose, this leaflet of the valve, what will happen to it?
Regurgitation. of the
Excellent. Yes. So a regurgitation murmur will occur. Make sense? Okay, excellent. So the next thing next. So we have the following written. An RCA supplies the SA node and the blood supply independent of the dominance. It doesn't matter if you are right dominance, left dominance, nobody care. You will have the same. So the infarcts may cause nodal dysfunction, bradycardia, or heart block. This is super important. Why? Because if we speak about the infarction, it can lead to nodal dysfunction, and this node, when the SA node is dysfunctional, the AV node will start working instead of it. That's like a good backup, but still it's much more slower. Yeah?
Yeah.
So you will have a bradycardia. Okay, the last vessel was the right marginal artery that supplies the right ventricle, and we spoke about it. It was the pink one of your choice. Yeah?
Yeah.
Okay, so this paragraph makes sense?
Yes.
By the way, the coronary arteries and the sublimate of the heart, if you did not memorize it now, it's okay, because we are going to speak about it in pathology again, deeply. So, let's speak about the dominance. I told you that there was a right dominance, left dominance, and codominance. So what do I mean by that? So, in a right dominance, where is the BDA originating from? Tell me, please.
Right coronary artery.
Excellent.
Yeah.
Yeah. So it's, as you can see, it's originating from the right coronary artery. Well, in case of left dominance, where is it originating from?
Left coronary artery. Left circumflux.
Okay, and if it's from both, what do we call it?
From left codominant.
Yep, excellent. So the right dominant BDA arises from the RCA, and left dominant the BDA arises from the left circumflux, while the codominant arises from both the left circumflux and the right coronary artery. Now I'm going to tell you about an important fact. So take a look here. During systole of the heart, your left ventricle is contracting or relaxing during systole?
Contract.
Okay, okay. When it contracts, will the aortic valve be open or closed?
Systole. Aortic valve is open.
Yeah, okay. When it opens, can you see where is the coronary artery opening located?
Yeah, like
Near the cusps. So when these cusps open, what will close? The coronary arteries will be shut, correct?
yeah.
So the sublimement of the coronary artery with the blood only happens during diastole when the valve is closed. Okay?
Yeah.
Got it? Did you get this concept?
Yes.
Can you repeat it back to me, please?
So like you say when during the systole, so the aortic valve is open, so like it's kind of stop the blood flow to the coronary artery. So during diastole, the valve is open, so like more blood flow to the coronary artery.
The aortic valve open or close?
Close.
Okay.
So like the blood flow will go to the coronary artery during diastole.
Excellent. So now you read coronary blood flow peaks in early diastole. Make sense?
Yes.
Okay, good. So you feel comfortable with this page? Anatomy of the heart was not that bad, yeah?
Yeah.
Okay, excellent. Well, we start with the devil. I hope you are ready. So, the physiology of the heart. A previous time I was speaking with you about contractility, preload and afterload, yeah?
Yeah.
Can you tell me something that increases your preload?
Increase preload. Like you mean
Anything that increases the volume. So, pregnancy.
the frequency, yeah.
Okay, or for example, injection of a lot of normal saline as well. Okay, what about the contractility? What increases your contractility?
Exercise.
Excellent. Okay, what else? Catecholamines, yeah? Like epinephrine or epinephrine. What about the afterload? What increases your afterload?
Decrease the afterload.
Increase the afterload. What increases your afterload?
I don't know.
Well, hypertension, yeah?
Yeah.
So keep in mind, what is preload, what is contractility, what is afterload? Really quick. So if we speak about the power at which the heart contracts, we call that contractility, okay? If we speak about, if we imagine that this is left atrium, left ventricle, and you have this aorta. The amount of the blood that goes back to your left atrium, we call that the preload of the left atrium. When it goes to the ventricle, we say it's the preload of the left ventricle, okay? When it goes back to the aorta, we say it's the preload of the aorta. So a preload is the amount of the blood that a cavity has to deal with, okay? Can you tell me please how many pulmonary veins do you have going to your left atrium?
4.
Excellent, yeah, they are 4. A lot of student thinks too, it's incorrect, they are 4. Okay, so the contractility is the power in which the heart contracts. The preload, we said, is the volume of how much he contracts. What about the afterload? It's how much pressure is going against the heart, okay? It's mediated by different factors, the afterload, including the viscosity, but mainly, which vessel?
The arterial.
Arterioles, yes, exactly, the precapillary sphincters of the arterioles. But it also can be from other factors like viscosity, like the stiffening of the aorta, like the aortic valve stenosis. But basically, afterload is any force that is pushing back to the heart, okay?
Yeah.
Okay, so let's take a look. Should I repeat this or should I continue?
You can continue. Yeah, I think.
Okay, good. So they write here a preload. A preload is approximated by ventricular and diastolic volume. So a ventricular and diastolic volume is how much blood the ventricle has to deal with at the beginning of systole. So end diastolic volume, what does happen during diastole? Do you have filling of the ventricle or contraction of the ventricle?
Filling of
Okay.
the ventricle.
If you have filling of the ventricle, so the amount that will be at the end of diastole will be the highest amount of the blood inside of the heart or the lowest amount of the blood inside of the heart?
The highest.
Highest, because it's the end of filling, correct? So
Yeah.
the preload is approximated by the ventricular and diastolic volume because the preload is dependent on how much blood you have inside of your left ventricle, for example. And thus, it's mediated by the end diastolic volume, how much filling has happened. And it depends on the venous tone and the circulating blood volume. You are like, okay, circulating blood volume, I get it. If you have more volume in your body, you have more preload. Make sense? So,
Yeah.
what about this venous tone? This is important. Let me show you. If we say that a patient has, let's say that this is superior vena cava, inferior vena cava, and they go to where? Right atrium. Yeah? And from the right atrium, they go to the right ventricle, and then they go like this, pulmonary trunk, and then you have the lung. After they reach the lung, they go to the left atrium, and they go to the left ventricle, and then they go to the aorta. Yeah? So just let's focus at this area. Here we have the inferior vena cava and the superior vena cava. So the inferior vena cava goes something like this. It has a lot of veins, and when you give a, like, let's say a drug, it will lead to vasodilatation of the veins, correct?
Yeah.
So the tone of the veins will go up or down?
Go down.
Yep, it will go down. When it goes down, the vessels are dilating. So if you dilate a vessel, will it accommodate more blood or less blood will be inside of it?
More blood.
More blood, exactly. So the more blood goes inside of the veins, the less blood will be going inside of the heart, correct?
Yeah.
And that leads to a decreased preload or an increased preload.
Decrease the preload.
Got it? So now you know exactly how nitrate works. Do you feel comfortable?
Yeah.
Okay, good. So that's basically when the venous tone decreases, your preload decreases, yeah?
Yeah.
While when your venous tone increases, you have more blood going back inside of your right ventricle, so you have more preload. Make sense?
Yeah.
Okay, good. So let's read. The preload is approximated by the ventricular and diastolic pressure depending on the venous tone and circulating blood volume. Vasodilators like nitroglycerin lead to decreased preload. You understood how this happened?
Yes.
Excellent. So afterload is approximated by the MAP, which is the mean arterial pressure. For now, please do not get confused a lot about this concept. I just want you, it's different, but for now I want you to imagine that MAP is the same as blood pressure, okay?
Okay.
So MAP is blood pressure, mean arterial pressure. So there is something called Laplace Law, okay? And that Laplace Law is super important. It means something like this. We'll speak about what it means in a second. Take a look. It means that if I have a tube and I increase the amount of fluid inside of it, yeah? More fluid inside of this tube, will the pressure go up or down?
Go up.
Yeah, that's correct. Okay, what about if I have fluid, if I have fluid inside of this tube and I make this tube much more narrow, what will happen to the pressure inside of the tube?
Oh. It's high, right?
Yeah, it's like exactly a water hose for the garden, you know? When you compress the hose, what will happen to the pressure inside of it?
It's high.
Yeah. Okay, what happens when you dilate the vessel? What happens to the pressure inside of it?
Pressure is low.
Excellent. Got it? So,
Yeah.
now let's speak what they're speaking about. So an increased wall tension or something called the Laplace Law increases the pressure and afterload. What does that mean? Well, if we imagine that this is the, just a sec, left atrium, left ventricle, you know, and you have more blood inside of your aorta, okay? And if there is more blood inside of the aorta, there will be more tension on the walls, correct?
Yeah.
So the pressure here will be higher or lower?
More tension, high pressure.
Yeah, exactly. So there will be more pressure, more MAB, obviously, yeah?
Yeah.
And that will lead to more afterload, which is the pushing back against the heart, correct?
Yeah.
Okay, so let's speak about that. That was the first cause, like increase the blood. Also, let's imagine that you have like a distal vessel coming outside from your aorta. If this vessels vasoconstrict, what will happen to your MAP?
Increase.
Excellent. So what happens to the afterload?
Increase the afterload.
And what is afterload? Is the pushing against the heart, yeah?
Yeah. Yeah.
If I vasodilate it, make it bigger, what will happen?
Decrease blood pressure and decrease the afterload.
Got it. So decrease the blood pressure. What about the afterload? What did you say?
Decrease.
Okay, good. So, and that makes sense. Are you comfortable with the Laplace law?
Yeah.
Okay, good. So left ventricular.
Can you say again like why the wall tension is related? How like wall tension related to the pressure?
Yeah. So take a look. If you have like a vessel and you have like a wall tension, what is it? It's the amount of the pressure pushed against the wall. Yeah?
Okay. Yeah.
So if you have more volume inside, more volume inside, so more volume. Imagine this for a second like a balloon, okay? If you have more water inside of the balloon, the wall become more tense or less tense?
I think tense.
More tense. It becomes like less flexible, yeah? More tense. So the pressure inside of the balloon goes up, correct?
Yeah.
The same idea here. When you have more volume inside of the vessel, it starts pushing against the wall of that vessel. And when that happens, by the Laplace law, when you have more pushing against the wall of the vessel, by the Laplace law, you will have more blood pressure, more MAP, okay?
Okay.
Make sense?
Yeah.
Okay, good. So more wall tension per Laplace law lead to more pressure and more afterload. So because look, if you are pushing against this vessel, he wants to close back, correct?
Yeah.
So he's fighting back, so the pressure will go up. So okay, the left ventricle compensates for the increased afterload by thickening. So you remember when we spoke about the afterload? Tell me please, is it A? Afterload is A. The power of which the blood is pushing against the heart. B. The amount of the blood inside of your left ventricle going outside. C. The power of contraction of the heart. Is the answer A, B, or C?
A.
Excellent. Good. So the left ventricle compensate for the increased afterload, because afterload is basically the pressure that is pushing back against the heart. How it compensates for that? By thickening, it becomes more thick. So the patient undergo the process of hypertrophy in order to decrease the wall stress. You're like, well, what do you mean by that? So basically, this is the afterload is increasing here, yeah?
Yeah.
And here in the left ventricle, it becomes much more thick, correct? Why? Because it needs to compensate for it, hypertrophy, yeah?
Yeah.
So when it undergoes the process of hypertrophy, it becomes much more thicker, and it can like actually initially overcome the afterload, because more thicker, more contraction, yes?
Yeah.
And the thicker it becomes, take a look at this. Remember, here the Laplace law, the main reason why the pressure increased was because of the pushing against the walls of the vessel. If I make the wall of the vessel much more thick, okay, much more thick, or the ventricle much more thick, the pressure will be distributed much more on that muscle, correct?
Yeah.
So if it will be distributed, that will reduce the pressure a little bit inside, yeah?
Yeah.
But this mechanism is not perfect. Basically, obviously, it will fail, but in the beginning it works. So they write, the left ventricle compensates for the increased afterload by thickening, well, basically hypertrophy, in order to decrease the wall stress. How? By increasing the distribution of the stress on the wall of the ventricle. Okay?
Yeah.
Okay, so the next thing you must know, it's basically arterial vasodilator, like a drug called hydralazine. Do you remember a drug called nitroglycerin? Did it work on the veins or the arteries?
It works on the veins.
Excellent. Now we are going to speak about a drug called hydralazine. Hydralazine is kind of the same, but the only difference is that it works only on the arteries, okay? Hydralazine, there is a few things you must know about it in the future we'll speak about, like it can induce drug-induced lupus. So yeah, that's interesting. So if it if it leads to arterial vasodilation, what will happen to your afterload? Think about it.
Decrease the afterload
Yeah, why?
because it's
Because more size will lead to more to what?
I mean, like when it dilates the arteries, the pressure will decrease.
Yeah, that's correct, because it will have larger size of distribution of the stress. Yeah, large surface area to distribute the stress. Okay, so they speak about some drug called ACE inhibitor and ARPS inhibitor. Do you remember something called the RAS system?
Yeah.
So it goes something like this. Tell me the steps, please. I started from what?
Angiotensinogen.
No, that's later. The first thing is renin, and renin converts what to what?
Angiotensinogen to angiotensin 1.
Okay, that's correct.
And then the ACE enzyme will convert the angiotensin 1 to angiotensin 2.
Can you tell me where is the ACE enzyme located? Which organ?
Is it in the kidney or lungs?
Lungs. This one is in the lungs, this one is the kidney. Okay?
Okay, yeah.
Okay, keep going. So you have your angiotensin 2. What's next?
And release aldosterone.
Okay, aldosterone will be more. That's correct. Where is aldosterone secreted?
In the adrenal gland cortex.
In the adrenal cortex, that is correct. Keep in mind that other function of angiotensin 2 is directly doing what? Vasoconstriction. If you have vasoconstriction of the arteries, will you have more afterload or less afterload?
Vasoconstriction. Is there more afterload?
Excellent. So if I speak about the aldosterone, aldosterone leads to what? The function of aldosterone, what it will lead to the sodium in your body?
Decrease.
No, aldosterone will increase the sodium because it reabsorbs it, okay? And it will decrease the potassium, okay? Well,
Yeah.
if it increases the sodium, remember that the sodium is basically salt, and salt like what?
Water.
Yep, it likes water. So more water will go inside of your body. So what will happen to your preload?
Increase.
Excellent, more preload. And when the vasoconstriction happened, what happened to your afterload?
Increase the afterload.
Okay, so you have increase of both your afterload and the preload. So if you can stop the function of these two guys, you can decrease both your preload and your afterload, which is a good thing. So that's why we use ACE inhibitors, okay?
Yeah.
Because they decrease both the preload and afterload. Look what they write. ACE inhibitors and ARBs inhibitor decrease both the preload and the afterload. Make sense?
Yes.
Okay, chronic hypertension increase your mean arterial pressure, which can eventually lead to left ventricular hypertrophy. By the way, keep in mind that the three tissues in your body cannot undergo the process of hyperplasia. They can only go the process of hypertrophy, which are 1. The heart, 2. Skeletal muscles, 3. The neurons. Okay?
The heart, skeletal muscle, and what is the last one?
Neurons.
Neurons. Okay.
Yeah, they cannot divide. They can become hypertrophic, but they cannot become hyperplastic. Because remember, hypertrophy is increase in size, while hyperplasia is increase in number. So they can increase in size, but they cannot increase in number. Okay?
Okay. Yeah.
Good. So the next one is myocardial oxygen demand. So think about this. If the heart is ischemic, he is ischemic, you want to reduce the demand of the heart for O2 or you want to increase it?
Increase.
No, if you increase the demand, he will become more ischemic. Look, let's imagine the situation is like this. This is your heart and this is the vessel supplying your heart. If the vessel has like 3 molecules of oxygen and the heart is requesting 5, yeah? If the heart is requesting 5 and only you give him 3, he will be sad. Basically, you are leading to his ischemia. He will start dying, yeah?
Yeah.
So, but if you reduce the consumption of O2 from the heart, if you make it like, instead of 5, you make it 2, and you supply him with 3 molecules, what will happen to your heart muscle? It will live. It will be happy, yeah? See the difference? So,
Yeah.
you must decrease the demand in case of ischemia, yeah?
Yeah.
Okay, so the demand of the O2, it's how much the heart needs O2. The less it is, in case of ischemia, the better. So what increases your O2 demand? Something that consumes a lot of ATP, basically, yeah? Because why do we need the O2? To make ATP, yes?
Yeah.
So the first thing is contractility. If you have more contractility, are you consuming more ATP or less ATP?
More ATP.
Yes, do you remember when I spoke with you about like inside of the heart muscles, we had this GS protein here, which was bound to a beta-1 receptor, remember? And when this was activated, the GS was activated and we had what? Increase of adenylate cyclase, yeah? And that helped in the conversion of ATP, CAMP. Okay, and that led to what? Activation of?
Protein kinase A.
Excellent. And that led to what?
Two things.
Yeah.
Phosphorylate and then
Phosphorylation of what?
phospholamban.
Yes, that was one, and that increased the calcium influx inside of the cell, inside of the sarcoplasmatic reticulum. That is correct. And the second thing it led to is
The changing.
Yeah.
And calcium.
Exactly. Activation of the exchanger to get more calcium inside of the cell. And when you have more calcium inside of the cells, you will have calcium-induced calcium release leading to contraction. So the higher the contractility, the more ATP you are consuming, correct?
Yeah.
Good. So they write here myocardial, and remember to make ATP, you need what? You need O2, correct? So
Yeah.
here they write the following. Myocardial O2 demand is increased by the following. The first one is contractility. The higher the contractility, the higher the O2 demand, which is a good thing or a bad thing?
Bad thing.
Exactly, bad thing. You need a less demand, not a more demand. Also the afterload. So the afterload will also be huge in case of if the afterload will be increased, your heart has to push harder or less.
Work harder.
Yes, to be able to overcome that pressure coming against him. Yeah, and
Yeah.
thus he needs more ATP or less ATP to work harder.
More ATP.
More ATP requests more O2 or less O2.
More O2 demand.
So the myocardial O2 demand increases in case of increased afterload. So can you tell me please regarding heart rate, if you activate the beta 1 receptor, if you activate the beta 1 receptor leading to higher heart rate, is that consuming more ATP or less ATP?
More ATP.
Yes, consuming more ATP, that's correct. Why? Because you are basically consuming more O2. So when you consume more O2, your O2 demand becomes higher. The last one is the diameter of the ventricle. So when your diameter of the ventricle is really, really large, like in case of dilated cardiomyopathy, let's say, for example, the ventricle wall is pretty large like this, okay? So
Yeah.
if that's basically like the diameter of the ventricle, just a sec, yeah, it's thicker. Will it need more ATP to supply all of that or less ATP to supply all of that?
More ATP.
Low ATP,
Supply.
low ATP will lead to a problem. Why? Because this is much more thicker. Okay, well, let's imagine that it was like this and now it's like this. So the wall is really thick. So it requests much more O2 than before, correct?
Yeah.
So if it requests more O2 than before, this is before of course, that means that you have high risk of what? Of infarction, because like the myocardial O2 demand has increased. Okay, so far so good. You feel comfortable with these concepts?
Yes.
Good. Let me add a few stuff. So wall tension follows the Laplace law. If you remember the Laplace law, it was what? It was like the wall tension is equal how much is the pressure against the wall, yeah?
Yeah.
So if you increase the volume, according to the Laplace law, what happens to the wall tension?
Increase volume. More pressure. More wall tension.
Excellent. So if you, for example, vasoconstrict the vessel, what happens to the pressure?
Vasoconstrict. More pressure.
Okay, good. So there is a different concept called wall thickness. Do you remember when I told you that left ventricular hypertrophy, does it increase the stress, the wall stress, or decrease the wall stress?
Increase.
Decrease. It was decrease the wall stress. Why?
Yeah.
Because it was able to distribute the pressure equally on the portions of the heart, correct?
Yeah.
So they write here the wall stress law. It's all useless, but the most important thing is to notice this one. The wall thickness, the bigger it is, what happens to the wall stress? It goes down. Why? Because it's an inverse relationship, yeah?
Yeah. I see.
Okay, good. You feel comfortable with this?
Yes.
Okay, good. So next thing we are going to speak about is stroke volumes. So the stroke volumes is how much blood is pushed outside of your ventricle. How much blood is pushed outside of your ventricle per one push, okay? Per one push, how much blood are you getting outside? So it is equal to, if we say that this is your let's do this. If we say that this is your left atrium, left ventricle, and aorta, okay? And then your stroke volume is how much blood will be pushed from here into here, correct?
Yeah.
So you can imagine that if you have, it's mediated by two things: how much blood was in the heart before systole and how much blood is left after systole, correct? So
Yeah.
end diastolic volume is how much blood inside of your heart after full relaxation, yeah?
Yeah.
So after full relaxation, whatever blood is left inside of your heart, we call it the end diastolic volume, yeah? And that will be the highest amount of the blood inside of your heart, correct?
Yeah.
If we speak about the end systolic volume, is how much blood is left inside of your heart after the end of systole, correct?
Yes.
So it will be the least amount of blood inside of your heart, correct?
Yeah.
So if I minus the most amount minus the less amount, it will tell you how much got out of from the heart, correct? So if I tell you the end diastolic volume, if I tell you that before the systole there was 120 milliliters of blood inside of the ventricle, okay? A contraction happened. After that contraction happened, now I have only like 50 milliliters of mercury. How much is the stroke volume? The stroke volume is equal to 120, which was like before the contraction, minus 50, which how much like is left after the contraction. So you can say 70 milliliters were pushed outside of the heart during the contraction. That is the stroke volume. Make sense?
Yeah.
Okay, let me give you, just to make sure, I will give you an end diastolic volume and end systolic volume, and you will tell me what is the stroke volume, okay?
Yeah.
If the end systolic volume was 100 and the end diastolic volume was 40, how much is the stroke volume?
Is it minus?
No, oh, sorry, my apology. 140, you are right.
Okay. So like 40 is the stroke volume.
Excellent.
140 minus.
Yep, got it. Excellent. Good. You feel comfortable with this concept?
Yeah.
Excellent. So the next concept we are going to speak about is the ejection fraction. So you are like, wait a second, that sounds exactly like the stroke volume. It's different. The stroke volume is how much blood got outside of the heart per one beat. And it was what? It was like a number, yes? It was like 100 milliliter, 40 milliliter, 30 milliliter. Now the ejection fraction, it's a fraction, yes? So
Yes.
since it's a fraction, it must be a percentage, correct? So the law tells you something like this. In case of speaking about the ejection fraction, it's equal to the stroke volume, how much blood was pushed outside of your heart per one push, divided by the end diastolic volume, which is how much blood used to be in your heart before the systole has occurred, which means like it's the most amount of the blood inside of your heart. Yes?
Yeah.
Ejection fraction is super important. Why? Because it can help you to diagnose heart failure. Do you know how much is a normal ejection fraction?
60%.
Yes, it's more than 60%, correct. If it was less than 55%, this is diagnostic of heart failure, okay? Systolic heart failure. So the ejection fraction, if I tell you, let me do this to you. If I tell you at the end of diastole, inside of the heart there was 120 milliliters of blood, and in the end of systole it was like 40. Can you tell me what is the ejection fraction?
40 minus. Oh no, 40 like over 120.
No, it's not 40 over 120. First of all, you had to calculate the stroke volume. How much is the stroke volume?
Oh yeah. So 60.
Okay.
No.
What's 60? No, it's not 60. It's 120 minus 40. It's 80.
Yeah, 80.
Mathematics. So, and for the diastole, for the end diastolic volume, how much it was?
And diastolic volume 120.
Excellent. So yeah, it's this number, 80 over 120. Yeah?
Yeah.
That's your ejection fraction. Okay, you are a little bit more comfortable with the ejection fraction?
Yes.
So ejection fraction is the stroke volume divided by the end diastolic volume. The stroke volume is the difference between the end diastolic volume minus the end systolic volume divided by the end diastolic volume. Speaking about the ejection fraction, it's an index of ventricular contractility. So a decrease in it represents systolic heart failure. But in case of diastolic heart failure, it will be normal. What does that mean? Well, ejection fraction can represent how good the heart is your heart contracting. Why? Because what is the relationship between the stroke volume and the ejection fraction? Is it inverse or proportional?
Proportional.
Yes, it's a proportional. And what is the relationship between stroke volume and contractility?
Proportional.
Excellent. So the more contractility you have, more systole you have, more ejection fraction you have, correct?
Yeah.
So in systolic heart failure, the ejection fraction will reduce because it's a problem in contractility. While in diastolic heart failure, the problem is in relaxation, not contractility. We'll speak about this later, but in diastolic heart failure, the problem is in the relaxation. So your ejection fraction will be normal. So you can see that if you can determine the ejection fraction, you can easily differentiate between systolic and diastolic heart failure, correct?
Yeah.
Okay, excellent. So, yeah, usually normal in diastolic heart failure. Good. So, we had the systolic, we had the diastolic, we had the stroke volume, we had the ejection fraction. So far, we explained everything about the anatomy of the heart, and we explained these portions of the cardiac output variables. Now we are doing the equations. Now we'll take a little bit of a long break. Break time is on me, as always. And after the break, we can keep going, okay?
Okay.
Now the break will be a bit long, so it's 15 minutes, okay?
Okay, yeah.
Okay, see you 15. Bye-bye.